Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module we are going to discuss about the part 2 aspect of fibroid. So in this part 2 module of fibroid we are going to discuss about the most important symptoms, the local examinations and investigations in a patient of fibroid. Right, in the part 3 module we'll be discussing about the treatment of fibroid. So the treatment of fibroid is actually a very big topic, that the treatment has to be decided upon the age of the patient and the desire of the patient as well. So it will be dealt in a detailed manner in the next module. So in this module we are going to discuss about the symptom complex and the investigations. Is that clear? Okay, so just a small gist for you. So fibroid is basically a smooth muscle benign tumor of the uterus, which is also called as leiomyoma, and in the last module we have discussed about the basics of fibroid, the Figo classifications and the different types of fibroid. So if you haven't watched that yet, please watch that module and then come back to this. Okay, so now having discussed about the general informations about fibroid, we are going to jump into the symptoms. So what is the most common presentation? So always please remember, the most common presentation is actually asymptomatic. The patient is not going to have any symptom, right? The patient will never have any symptom, and only during some other compliance you are going to do ultrasound for some other purpose, and on incidental finding you're going to find out that there is a fibroid which is situated in the uterus. So most common presentation in a case of fibroid is always asymptomatic, that is discovered only incidentally, where the patient has come to you for some other complaint, and for some other complaint you have ordered an ultrasound to be done, and on the ultrasound you get the information that a fibroid is present in the uterus. But if the patient is symptomatic, what is the most common symptom? If the patient is symptomatic, the most common symptom is heavy menstrual bleeding, which is also known as menorrhagia. Why? It is because of the fact that we all know that fibroid is a hyperestrogenic condition. So what do you mean by hyperestrogenic condition? Increase in amount of estrogen in the body. This fibroid, which is a smooth muscle tumor, is dependent upon the estrogen for its growth and development. So whenever the amount of estrogen is going to be increased in a female's body, because of increased estrogen, there is going to be hyperproliferation of the uterine endometrium. So because of the proliferation of uterine endometrium, there is going to be increase in thickness of the uterine endometrium. And because of that fact, the patient is going to have increased amount of bleeding per vagina, that is heavy menstrual bleeding, which is also called as menorrhagia. So the most common symptom is going to be menorrhagia, which is also called as heavy menstrual bleeding. Followed by the other symptoms could be secondary dysmenorrhea. So what do you mean by secondary dysmenorrhea? If you recall, we have discussed in the previous module, the second module of gynecology was dysmenorrhea. So dysmenorrhea is pain during menstruation. Secondary dysmenorrhea means secondary to some other pelvic pathology, the patient is having this painful menstruation. And the pelvic pathology in this case is fibroid. So fibroid is a benign smooth muscle tumor of the uterus. Uterus is situated in the pelvic cavity. So because of secondary pelvic pathology, the patient is having painful menstruation. So secondary dysmenorrhea can be as such, it could be either painful menstruation, or the pain can also be due to some different reasons. What it could be? It could be because of some infections of the fibroid, any kind of degeneration where the fibroid is going to get degenerated, degeneration of the fibroid, red degeneration of the fibroid during pregnancy. This condition happens only during the pregnancy, so red degeneration of the fibroid. And if the fibroid is going to happen some malignant transformation, which is a very rare phenomenon, but then if malignant transformation is going to happen in that fibroid, it can result in some pain. So the pain symptom complex could be as such secondary dysmenorrhea because of secondary pelvic pathology, or it could be because of degeneration of the fibroid or malignant transformation of the fibroid. Okay, yes. So the first symptom was menorrhagia, the second symptom was secondary dysmenorrhea. The third symptom complex is the pelvic pressure. So what do you mean by pelvic pressure? So pressure means the fibroid is actually a smooth muscle tumor, right? It is a hyperestrogenic condition. It is dependent on estrogen for its growth and development. So as the amount of estrogen is going to remain high in the patient body, the fibroid is going to grow and it is going to develop in size. So as the size of the fibroid is going to increase, it is going to result in increase in size of the uterus, which will be visible as abdominal distension, where the uterus could be compared to a 16 to 18 weeks pregnant uterus size. Right, 16 to 18 weeks pregnant uterus size can be compared to a case of fibroid. Right, it can get enlarged even to about 18 weeks of a pregnant uterus size. So as the size of fibroid is going to increase upon conception of this estrogen by the fibroid, it is going to exert some pressure to the surrounding structures which have been present. So if the fibroid is situated in the anterior part, the part which lies close to the anterior part of the uterus or the cervix is the urinary bladder and the urethra. So if this fibroid which is situated in the anterior part, it is going to exert the pressure on the urinary bladder, it is going to result in symptom of increased in urinary frequency. Right, if it is going to exert the pressure on urinary bladder, it is going to result in increase in urinary frequency. But if it is going to exert the pressure on the urethra, it is going to result in urinary obstruction. Urinary obstruction. As you can see here, this is the uterus and this is the bladder, urethra, bladder, and this part is going to be the rectum. So if the fibroid is situated in the anterior part and it is going to increase in size and it is going to exert the pressure either on the urethra or on the urinary bladder. If it is going to exert the pressure on the urinary bladder, increase in urinary frequency will be the complaint. If it is going to exert the pressure on the urethra, the complaints will be urinary obstruction. Okay, yes. Similarly, if it is going to exert the pressure, if the fibroid is situated in the posterior part and if it is going to exert the pressure on the rectum as it is going to enlarge, it is going to result in constipation, because we all know that rectum is loaded with the fecal matter. So if it is going to put pressure on the rectum, all the fecal matter will be dislodged very slowly, which is going to result in constipation. So anterior part, increase in urinary frequency, urinary obstruction. Posterior part would be constipation. What about the lateral part? If the fibroid is going to be situated in the lateral part in relation to the uterus and cervix, what is situated in the lateral part? As we all know, ureter is lying in the lateral part of the uterus. So if the fibroid is going to exert the pressure on the ureter, it is going to result in, because of the obstruction which is being caused by this increase in size of the fibroid, it is going to result in hydroureter. Right, it is going to result in hydroureter. So because of the obstruction of the ureter, which has been made by the increased in size of the fibroid over the ureter, so the ureter gets obstructed. So all the urine which is going collected, it is going to get collected proximal to the site of the obstruction. So if the site of obstruction is going to be here, proximal to the site of the obstruction, it is going to be engorged. So this is called as hydroureter. Right? Yes. So this was all about the symptom complex. So the most common symptom was menorrhagia, followed by secondary dysmenorrhea, and then we discuss about the pelvic pressure, anterior part, posterior part, and the lateral part. Clear? Yes. So now we have a quiz for you. So the most common fibroid to cause menorrhagia is what fibroid? So as we all know, inside the endometrial cavity, the most common fibroid to occur is the submucosal fibroid. We have three types of fibroid: submucosal, intramural, and the subserosal. Which happens inside the uterine cavity? Submucosal. Menstruation happens because of the shedding of the endometrium, which happens in the uterine cavity. So since this fibroid is situated in the uterine cavity, the most common fibroid to cause menorrhagia is the submucosal fibroid. Submucosal fibroid is the most common fibroid to cause menorrhagia. Is that clear? Yes. And which is the most common fibroid which causes the pressure symptoms? So the most common fibroid to cause the pressure symptom is actually the subserous fibroid. Right? right? Any fibroid can cause such symptoms, but the most common fibroid to cause the pressure symptom is the subserous fibroid, which is situated in the serosa, and the most common fibroid to cause menorrhagia, increased amount of bleeding or heavy menstrual bleeding, is the submucosal fibroid, right? So these are the most important questions. And the fourth important symptom complex could be infertility. What is infertility? Inability of a couple to conceive even after 1 year of having unprotected sexual intercourse. So even after having 1 year of unprotected sexual intercourse, that is without the use of any oral contraceptive pills or any methods of contraception, they are not delaying their conception. They are doing unprotectedly, they are doing the sexual intercourse, and instead of doing the unprotected sexual intercourse, the patient is having infertility. So you can term a patient as infertile only after 1 year. So 1 year after the marriage, after 1 year, for 1 year period of time, the patient should have unprotected sexual intercourse with her partner. So only after 1 year of having unprotected sexual intercourse, if the patient is not having any conception, you can term the couple as being infertile. Not in 6 months, not in 3 months. Only after 1 year of having unprotected sexual intercourse, you can define a couple to be a case of infertility. Clear? Yes. So infertility is also a symptom of fibroid, because solitarily this infertility, fibroid as a cause for infertility occur for around 1 to 3% of cases. So around 1 to 3% of cases, the cause of infertility is fibroid. And the most common type of fibroid where infertility occurs is the submucosal fibroid. Why? Because submucosal fibroid is the type of fibroid which occurs in the uterine cavity. So since this fibroid is going to be situated in the uterine cavity, it can cause some hindrance with the implantation of the blastocyst. So problems with implantation can happen, and also the ascent of the sperms. There may be difficulty for the sperms to ascend inside the female reproductive tract. So the problems could be either due to the ascent of the sperm, or it can happen because of some problem which happens with the implantation. So if the fibroid is going to occupy the uterine cavity, so since this fibroid is occupying the uterine cavity, this blastocyst might not have any space left for implantation. It has to be implanted very deep in the endometrium, and since the endometrium is lodged with this very large fibroid, it is going to be a hindrance for this blastocyst to get implanted in the uterine endometrium. Right? It has to be implanted eccentrically. So because of that failure in implantation, the patient might have been infertile. So because of the problem with implantation or because of the problem with the ascent of the sperms, the patient can have difficulty in conception, so which is called as infertility. Fibroid can also cause recurrent pregnancy loss. Right, fibroid can also cause recurrent pregnancy loss. The most common symptoms are the menorrhagia, followed by the secondary dysmenorrhea, right, and followed by, we discuss about the pressure symptoms and the infertility. So infertility as a cause, fibroid is a separate solitary cause for infertility, which accounts for about 1 to 3% of the cases. And the most common type of fibroid to cause infertility is the submucosal fibroid, as it occurs in the uterine cavity. The problem could be with the implantation, or the problem could be with the ascent of the sperms because of the dislodgement of the fibroid. So the patient might have pregnancy loss, or the patient might be infertile. Either she can get conceived and she might result in pregnancy loss, or she might not have conceived because of the problem of fibroid, right? Okay. So until now we have discussed about the most important symptom complex of fibroid: menorrhagia, dysmenorrhea, pelvic pressure, and infertility. But always remember, the most common presentation is the asymptomatic presentation, because most cases it is going to be a very incidental finding, right? Okay. So now we are moving to the examination. So in a patient of fibroid, if you are going to do the examination, you have to do the per abdominal as well as the per vaginal examination. So per abdominal examination, the uterus will actually be enlarged. Why the uterus is going to be enlarged? Because I told you that fibroid is a hyperestrogenic condition. As the amount of estrogen is going to be increased in the female body, the fibroid is going to increase in size. So the fibroid is going to grow and develop. As the size of fibroid is going to increase, it is going to result in increase in size of the uterus, which will be evident as abdominal distension. So the uterus will be enlarged in the per abdominal examination. Up to 16 to 18 weeks uterus size could be that. 16 to 18 weeks pregnant uterus size can be compared to a case of fibroid also. So the fibroid can be enlarged very big, which could be compared to a 16 to 18, even more than that of a pregnant female's uterus size. And it is going to be irregular in consistency, and it is going to be firm, and the size could be around 16 to 18, or sometimes even more than that, 20 weeks gravid, which is pregnant uterus size. So the uterus is going to be enlarged, it is going to be irregular, firm, and it is compared to a 16 to 18 or even more than that pregnant uterus size. Clear? Yes. And in per vaginal examination, what are you going to do in the per vaginal examination? So when you do the per vaginal examination, you can find that the uterus is again enlarged and it is irregular, but no tenderness will be present. As you are going to palpate the uterus in the per vaginal examination, the patient is not going to have any such pain, but definitely the uterus is going to be enlarged and it is very irregular because of the size of the fibroid. It is going to be irregular and enlarged, but the patient will not have any pain because of your palpation, right? So no tenderness is going to be present. So this is the most important examination finding, per abdominal and per vaginal. Basically the uterus is enlarged, it is irregular and firm in consistency, right? Okay. So now we are moving to the gross features. So as you can see in this image, this is the gross specimen of a case of fibroid. So basically fibroid is white in color and it has a whorled appearance. As you can see here, this is the whorled appearance of the fibroid. It has a whorled appearance, and why it has a whorled appearance is because it is surrounded by a capsule, and this capsule is actually a pseudo capsule, and the blood vessel which supply this fibroid is running in this pseudo capsule. So fibroid is basically white in color. It has a whorled appearance and it is surrounded by a pseudo capsule, and this pseudo capsule has the blood vessel which supplies the fibroid. So basically in the periphery of the fibroid, the blood vessel supplying the fibroid is situated. At the same time, if you are going to do a cross section of the specimen of case of fibroid, it is going to be irregular, and the most important point is that it arises from a broad base. It arises from a broad base. So this is the differentiating feature between a fibroid and a polyp. A fibroid arises from a broad base, whereas a polyp arises from a narrow base. So let's say, for example, this is the uterus. Fibroid will arise from a broad base, but the polyp will arise from a narrow base. So polyp arises from a narrow base and fibroid arises from a broad base. So it's the most important differentiating feature. Is that clear? Yes. So basically fibroid is white in color, whorled appearance, surrounded by pseudocapsules. Blood vessel supplying the fibroid is present in the pseudocapsule. In cross section it is very irregular and it arises from a broad base. The differentiating feature between fibroid and polyp is that fibroid arises from a broad base and polyp arises from a narrow base. The blood vessels supplying the fibroid are situated in the periphery in the pseudocapsule, whereas the polyp, the blood vessel is running in the center of the polyp. So central feeding vessel sign, central feeding vessel sign is positive in a case of polyp, because the blood vessel is actually situated in the center part of the polyp, whereas in the fibroid, if this is the capsule, the blood vessel supplying the fibroid is present in the pseudocapsule. Clear? Yes. So this is all about the gross examination and the per abdominal and per vaginal examination in a case of fibroid. Now we are moving to the investigation of choice. So what are the different investigations which can be done in a patient of fibroid? So the most important investigations you're going to order to a patient who is complaining you of heavy menstrual bleeding is UPT followed by urine pregnancy test, right? Urine pregnancy test is going to be negative, followed by you're going to order ultrasound. So once you're going to do the ultrasound, you will be able to elucidate the presence of fibroid in the uterus or anywhere it is present, right? So ultrasound is going to be the investigation of choice. But for certain fibroids, there are certain other investigations which are even more sensitive than the basic ultrasound. Those are the fibroid which is situated in the uterine cavity, that is the submucosal fibroid. So any fibroid which is situated in the uterine cavity, what is the investigations? You can elucidate it with the help of hysteroscopy. Why? Because it's that hysteroscope is an instrument, right, with which you can visualize the interior of the uterus, and you can also visualize the tubal osteas, the cervix, the endocervix, and everything. So in order to inspect any fibroid, or let's say any focal lesion which is situated in the uterine cavity, hysteroscope can be used as an investigation. So if you're going to do hysteroscopy, you will be able to see this submucosal fibroid which is situated in the uterine cavity. Or you can also do hysterosalpingogram. What is hysterosalpingogram? Hysterosalpingogram is a procedure where an instrument which is called as Leach-Wilkinson cannula is used, through which you're going to inject a dye, and this dye has to pass inside the uterus, with which you're going to elucidate the tubal patency. So that is a test in order to check for the tubal patency. But here hysterosalpingogram is used because, let's say for example, as you can see in this image, this cannula is the Leach-Wilkinson cannula. So through this Leach-Wilkinson cannula, you can inject either normal saline or you can inject any dye. If you're going to inject any dye, this dye, if the tubes of the uterus, if the fallopian tubes of the uterus are patent without any obstruction, this dye has to pass all around the uterus and the tubes, and it has to exit via the fimbrial end of the fallopian tube. So this test is basically used to assess the patency of the fallopian tube, whether the tubes are obstructed or it is very patent. But here we are using this hysterosalpingogram in order to find the presence of any submucosal fibroid, that is any fibroid which is situated in the uterine cavity. That is, I'm going to inject normal saline inside. So as I'm going to do the saline infusion here, I have to visualize the interior of the uterus. So I'm going to inspect whether the uterine cavity is evenly distributed with the saline, or there is a filling defect. If there is a filling defect in the uterine cavity, that filling defect could be the fibroid, right? So as you can see here, you are injecting this normal saline which is gray in color, and all this part, the normal saline has been filled except this one part. So the part which has a filling defect in the uterine endometrium, that part could be a fibroid. So this procedure is called as saline infusion sonography. Basically, you're going to do the ultrasound, and while doing the ultrasound itself, you're going to inject the normal saline with the help of Leach-Wilkinson cannula, which is inserted inside the vagina of the female. As you're going to inject the normal saline, this saline has to evenly fill the uterine endometrium. If the saline is not filling one such particular part, that particular part could be a submucosal fibroid which is situated in the uterine cavity. As you can see here, the entire part of the uterus is filled with normal saline except this one part. So this one circular part which has a whorled appearance, which is situated in the uterine cavity, is the submucosal fibroid, right? Yes. So in the ultrasound, you will be able to elucidate the presence of a fibroid. So ideally, ultrasound is the investigation of choice, but for certain fibroids which is situated in the uterine cavity, investigations such as hysteroscopy, where you're going to visualize the interior of the uterus and elucidate where the fibroid is actually present. And you can also do hysterosalpingogram, a procedure called as saline infusion sonography. You are going to infuse the saline, and sonography, you are going to do the ultrasound and check whether there is a filling defect has been present. If a filling defect is present, more likely it is to be a submucosal fibroid which is situated in the uterine cavity, right? Yes. So this is all about the investigations in a case of fibroid. Now we are moving to the degeneration of fibroid. So what is actually going to cause the fibroid to degenerate, or what is going to cause the fibroid to shrink in size? So this degeneration of fibroid can happen when there is hormonal changes happening in a female. Because of hormonal changes, there could be decrease in amount of estrogen in the female's body. As we all know, fibroid is a estrogen dependent tumor. If the amount of estrogen is going to decrease, the fibroid is going to shrink or degenerate. If the patient has attained menopause, you need not worry about the fibroid, because as soon as the female is going to attain menopause, the amount of estrogen in her body is going to decrease. So thereafter, there is going to be cystic degeneration, that is liquefactive degeneration of the fibroid, which is a normal phenomenon. And in cases of decrease in blood supply to the fibroid, when there is decreased blood supply to the fibroid will actually shrink and degenerate. And in cases of pregnancy, there could be degeneration of the fibroid as well. But in the same case, during pregnancy, there are increased chances for the fibroid to increase in size. So usually during pregnancy, fibroid has the highest chances to increase, grow and develop. But at the same time, there are increased chances for this fibroid to degenerate during the pregnancy. So we will take care of it now, which is called as red degeneration of the fibroid. So degeneration of fibroid, if it happens in pregnancy, it is called as red degeneration of fibroid. And this is because in the second half of the pregnancy, there could be thrombosis in the blood vessels which is supplying the fibroid. So basically, if you see, this is the fibroid and this is the pseudocapsule and this is the blood vessel which is running in the pseudocapsule. If there is going to be any thrombosis in the blood supply, thrombosis in the blood vessels which is supplying to the fibroid, because of the decrease in blood supply to the fibroid, there could be infarction. Decrease in blood supply could result in infarction, and further it will result in red degeneration, where the size of the fibroid is going to shrink. So because of the thrombosis, which is going to result in infarction and decreased blood supply to the fibroid during pregnancy, the fibroid is going to degenerate or shrink, which is called as red degeneration of the fibroid. But at the same time, during pregnancy, fibroid can actually grow and develop. Clear? Yes. So in a case of red degeneration of fibroid, is it an emergency? As the term says, red degeneration of fibroid is an emergency? No, it is not an emergency actually, where you need to do only the conservative management. The patient will have symptoms such as nausea, vomiting and abdominal pain. So whenever there is degeneration of the fibroid, there would be abdominal pain. So the patient might have abdominal pain, nausea, vomiting and etc. If you're going to do investigations in such patients, there is going to be increase in erythrocyte sedimentation rate, and the WBCs will be more than 15,000. Up to 15,000 is actually physiological in pregnancy. So increase in WBC up to 15,000 is actually normal in pregnancy. But if the amount of WBC is going to be more than 15,000, it has to be considered. So if you do investigations in a patient of fibroid during pregnancy, the ESR, erythrocyte sedimentation rate, is going to increase, and the WBC is going to be increased, where it is going to be more than 15,000. Clear? And the management is nothing. You have to reassure the patient, do the conservative management. Whatever symptom the patient is having, do the symptomatic management. You need not do anything. You need not terminate the pregnancy. There is no need to give any antibiotics to the patient, and you need not worry about the fibroid. As the fibroid has got degenerated, you need not remove the fibroid. So I have written here, no role of myomectomy. What is myomectomy? Ectomy means removal. Ectomy means removal. What do you mean by myoma? Myoma is a fibroid. So removal of the fibroid need not be done in a case of red degeneration of fibroid. At the same time, you should not give any antibiotics. There is no need to give any prophylactic antibiotic, and there is no need to terminate the pregnancy, right? So just conservative management is enough. Do the symptomatic management and reassure the patient. Clear? Yes. So coming to the last part of this module, fibroids will increase in size by about 20 to 30% during pregnancy. So there could be two chances in pregnancy. Either because of the thrombosis in the blood vessels supplying to the fibroid, that could be red degeneration of the fibroid, which happens during pregnancy. But at the same time, during pregnancy, there are increased chances for this fibroid to increase in size by 20 to 30%, right? So fibroid can actually increase in size, grow and develop during pregnancy. At the same time, it can get degenerated because of some thrombosis which results in infarction and decreased blood supply to the fibroid. Clear? Yes. So the most important topic here is pregnancy and fibroid. How pregnancy and fibroid is interrelated. So there could be certain complications when we are discussing about pregnancy and fibroid. So I've divided into antepartum period, intrapartum and the postpartum period. Antepartum period is when the patient is pregnant. Intrapartum period is when the patient is in labor or during delivery process. Postpartum is when the patient has given birth to her child. So during the antepartum period, because of this fibroid coexisting with the pregnancy, there could be increased chances of abortion, which we call as pregnancy loss. Or there could be abruptio placenta, where there is premature separation of the placenta, which is called as abruptio placenta. There could be preterm labor. Even before the term period, term gestation, less than 37 weeks, the patient might deliver her child. So preterm labor can happen. And malpresentation. The ideal position is the cephalic presentation, where the head of the fetus should be lying near to the earth. But instead of the head, either the buttock region or some other presentation such as transverse lie, breech presentation could be present, because along with the child there is going to be the fibroid which is present in the uterus. So because of the fibroid and the pregnancy which is developing in the uterus, there could be malpresentation of the fetus. And as we all know, in the second trimester, the most common phenomenon, red degeneration of the fibroid, can happen. So red degeneration of the fibroid happens most commonly during the second trimester. Okay, so these are the antepartum complications. What are the intrapartum complications? So intrapartum, it can result in increase in chances to do the C-section. Vaginal delivery might not be possible because of increase in size of the fibroid, which is occupying the uterus. So increase in chances for C-section. And then it can also result in retained placenta. The placenta might not be separated and removed in toto. So there may be retained placenta because of the fibroid which is present in the uterine cavity, and there could be uterine inversion. What is uterine inversion? Uterine inversion is where the fundus of the uterus is going to come out pervaginally. So as you can see here, let's say this is the fundus of the uterus. So this inversion is where the fundus part is going to come out pervaginally. So if this is the vaginal tract, this is going to get inverted, right? The fundus is going to come down and this portion is going to come up. The uterus is going to get inverted and it is going to come out through the vagina. So this is called as uterine inversion. So uterine inversion can also happen because of fibroid during the intrapartum period. So increase in chances of C-section, retained placenta and uterine inversion are the complications which are anticipated in the intrapartum period in a case of fibroid during pregnancy. And in the postpartum period, because of retained placenta, there could be postpartum hemorrhage, there could be subinvolution of the uterus. The uterus might not get contracted fully after delivery of the child. There could be subinvolution of the uterus, and there could be some infections which happens in the postpartum period, which is called as puerperal sepsis. Sepsis is infection and puerperal is the period after the delivery of the fetus. So puerperal sepsis. So postpartum complications are postpartum hemorrhage, bleeding, pervaginal, subinvolution of the uterus and puerperal sepsis. The period of few weeks after the delivery of the fetus, that is called as puerperium. So during this puerperal period after the delivery of the fetus, infections in the blood which is called as sepsis. So puerperal sepsis, postpartum hemorrhage and subinvolution of the uterus, where the uterus is not involuting well. The uterus is not getting contracted back to its normal state. Because of the presence of fibroid, the uterus is not contracted to its original state. So antepartum, intrapartum and postpartum complications which in a case of fibroid with pregnancy. So please take a screenshot of this case. If there is a question of fibroid in your upcoming examinations, if you write this term pregnancy and fibroid and divide it into 3 subcategories and write, it might help you in getting some extra marks. So antepartum, abortion, abruptio placenta, preterm labor, malpresentation, red degeneration which happens in the second trimester. Intrapartum, increase in chances of C-section, retained placenta, uterine inversion. Postpartum hemorrhage, subinvolution of the uterus and puerperal sepsis which is the infection. Right? So this is all about the pregnancy and fibroid. So I hope in this module we discuss about the most important symptom complex, followed by the per abdominal, per vaginal examinations, the gross features, the investigations, and degeneration of the fibroid and red degeneration of fibroid during the second trimester of pregnancy. And we also discuss about the fibroid and pregnancy. So I hope it is very clear for you. In case you have any doubt, please write to us in the Mackler handle. So I will just soon reach out to you as early as been possible, and please subscribe to this Mackler YouTube handle and Instagram for regular daily video modules and quizzes. Right? So let's meet in the next module where I'll be discussing about the treatment of fibroid. Right? Yes. So until then, please keep studying and just revise when you come to watch the next module. Please revise the part 1 and part 2 module and then come to watch the part 3 module. Thank you.